So we are now ready to begin our next session here at the World Congress. And I've been really looking forward to this next session where we're going to talk about artificial intelligence in systemic sclerosis, about empowering patient support. I will be the moderator, and it is my great pleasure to introduce to you John Pauling, Janet Pope, and Edith Brown, who is going to give each a talk. Before that, I have a question to you in the audience. How many of you have used AI within the last week?
Everyone, good if they got a flight.
Okay, thank you. That's quite extraordinary, and now we are going to dig into the AI and what we can do about it. AI has existed for many years, and we know that in November 2022, the AI period just came like a waterfall into our heads, and because the company OpenAI introduced ChatGPT to the world. And within a couple of weeks, they gained more than 100 million users. So that is quite extraordinary, and it's making it the fastest growing consumer software application in history. And if you look into the statistics of the top 5 most visited websites globally, ChatGPT is on top 5. So it has really done a huge thing for the human, how we use internet information in general. These large language models are designed to generate a human-like text, and they can carry out wide specific variety of tasks. It's like, I'm going to prepare for a travel to Brussels next week, and I want to have an idea on how to prepare my my visit there. Or you can say, I want to know about specific areas. So it's all about composing music. It can do scripts. It can make you fairy tales. You have seen in the session where I gave a patient talk on nutrition that it can also do images. So it's the question that I am quite eager to know about is, how safe is it to use when we are talking about rare disease like systemic sclerosis? There are some risks about using the AI, and now I'm putting on my working glasses because, as you know, I'm a librarian and I work with critic information all the time. So there is a risk for inaccuracy or even outdated information, and you have to know about this. It doesn't know medicine, it just gives you the idea of what it thinks that you want to know. So there is some false confidence in it. The responses are written in very different languages, and some might even be wrong because the models are trained in all different kinds of information that is available out there. And as you know, in these days, we also see a lot of misinformation out there, not only in scleroderma, but in general. So it can be very easy to rely on the information which we found. I used to say, stay off Dr. Google. Now I'm actually adding, okay, be a little bit critical when you use Dr. ChatGPT. An important thing that I think is important to be aware of is that do not share your personal information with it, because then it's out there for the rest of the decades. There is a risk of replacing the professional advice, and I cannot emphasize enough that it is okay to find information, but you have to drag in your medical advisor because they have your history, know about the information. But there are some good things about using these large language models, because they can translate those complex texts that you might find you want to know about. They can translate even to your own language. They can help you understand specific topics. And it can help you prepare your visit at the physician the next time, like figuring out what questions are relevant for me when I ask you to do this. So, and then it can quickly summarize complex literature from fields like medical contact. I see many benefits of it, but as I say to my high school students when I teach them in lit information search, you have to be chronic critic. Not only living with a chronic disease, but chronic critic when you search about information. And with that, I have been looking really forward to inviting the panel to the stand. And the first one will be Dr. John Pauling, who is a consultant rheumatologist and associate professor in the School of Translational Sciences at the University of Bristol. John has long-standing research interest in the systemic sclerosis and Roennow's phenomenon. He is the vice president of the Scleroderma Clinical Trials Consortium, SCTC, and co-chairs at the OMERAC Systemic Sclerosis Digital Vasculopathy Special Interest Group.
Excellent. Well, thank you so much for inviting me to talk about a subject I know very little about. So this is definitely an area where I'm very intrigued to see how AI really will begin to support us as clinicians and supports our patient community for a condition in which we need information. Clinicians need information, and most importantly, patients require good information to help them navigate what can be a very difficult and challenging diagnosis. So I'm going to focus on the early diagnosis and patient support and how artificial intelligence may be able to support people thinking about or worrying about and living with early systemic sclerosis. So I've broken my talk into 4 parts. The first is avoiding diagnostic delay in systemic sclerosis. I'm sure there may be people in this room who, for many years, attended their primary care physicians telling them, I know there's something wrong, and were being told, you've just got cold hands, or you just have Raynaud's, and in actual fact, there was something more serious the matter. We know this is a really important unmet need in scleroderma, and one in which AI may be able to support us. I'll talk about how AI can support patients to learn more about their disease, how it will have potential at supporting clinicians in earlier diagnosis and, more important, prognosis. So that crystal ball, what does the future hold for this person? And then making sense of complex medical interactions. So avoiding diagnostic delay. So how can patients utilize AI to help establish a possible cause for new symptoms? So I've typed into the Google AI here, my fingers are sensitive to cold and go white and blue. What is wrong with me? You know, we know that it's very difficult to see a doctor at a convenient time and place. And most of us now, if there's something the matter with whether it's our central heating or our own bodies, we'll first go to Google to get some answers. And I have to say, I'm very impressed with what AI has told us here. This is good information. Correctly identified that you're likely experiencing Raynaud's symptoms. They've talked about the fact that Raynaud's symptoms can be associated with, or can be primary in nature, in which there is no underlying cause or disease driving the process, and often occurs in young people, aged 15 to 30. But I'm delighted to see that the AI model is already identifying rarer autoimmune rheumatic diseases such as systemic sclerosis as being important causes of secondary Raynaud's. It also is giving you early advice as when you should see a doctor. So if your symptoms have come on late, or if you've developed sores on the fingertips, this is absolutely the information that we share with primary care physicians when we're talking to them about Raynaud's phenomenon. Unfortunately, we know that the diagnostic delay is still a problem. So I've slightly extended the question here. I've said, I've got cold white fingers, I get acid reflux in my gullet, and my fingers have become fatter than normal. What is wrong with me? And again, AI is performing quite well here. You should see a doctor promptly for an evaluation. These are all red flag symptoms. And I think AI is actually picking up on red flags here that not all family doctors, primary care physicians might necessarily pick up on. And it indicates a lot of the symptoms, these red flags, that would certainly make me and many of you in the room will recognize these symptoms as being important markers or predictors that perhaps there might be something more serious going on. So we did a little bit of research using the UK's CPRD, which is this huge database of 20 million UK residents, where you can effectively look at their primary care records and see what symptoms people have been going along to see their primary care physicians, their family doctors about at any point in their disease course. All of the patients who are enrolled in the CPRD have given their consent for this completely anonymous data to be shared. And when you look at this group level data, we were able to identify nearly 1,800 patients who we were convinced had definitely had systemic sclerosis. And we looked back in their medical record to see, had these people ever gone along to their family care doctor to report Raynaud's symptoms prior to their scleroderma diagnosis? Now, thankfully, in nearly a third of cases, they'd been within the last year. So there was a very short period between first going along with Raynaud's symptoms and receiving a diagnosis of systemic sclerosis by a rheumatologist. But in nearly a quarter of patients, there was a 10-year delay from them first experiencing Raynaud's symptoms, well, not experiencing, but actually taking the time to go and see their family doctor to report Raynaud's symptoms and actually getting a diagnosis of systemic sclerosis. So this is 10 or more years in which patients haven't been adequately educated, monitored, assessed, and treated for what almost certainly was early systemic sclerosis. So we recognize this as an important unmet need. And hopefully AI will support patients to actually go along to their GPs and say, I'm concerned, there's something wrong with me, and the computer's telling me it may be this. That's going to be, I think that will hopefully shorten or reduce this problem in the future. So what about learning more about the disease? Now, one of the hardest parts of my job is telling people they have systemic sclerosis. No matter how much time and effort I take in that initial consultation, I know that within 15 minutes of leaving the room, the first thing they're going to do is Google systemic sclerosis. And there is nothing more terrifying than the opening page of Google Images. The problem with the internet is often, and certainly with Google Images, often you see a lot of worst case scenarios. And one of the things you will have learned from this meeting is how many different faces systemic sclerosis has. We say it's a very heterogeneous disease, which means it can affect patients in very, very different ways. So typing in systemic sclerosis into Google really gives you lots of detailed information, but a lot of scary information and information that might actually not be relevant to yourself. And it often lists these worst-case scenarios across multiple organ systems, such as the lungs, the heart, the kidneys. So Janet Pope, who'll be talking to you very shortly, she did a really lovely paper a few years ago where she talked about the 15% rule in scleroderma. And one of the things that's interesting when you look about across all patients with systemic sclerosis, so if you took 100 patients with systemic sclerosis, only 15 of those people will ever develop problems with their kidneys. Only 15 of those people will have really repeated ulceration of their fingers. Only 15 of those will get severe progressive scarring on their lungs. And that means that 85 people will not develop any of those complications. And one of the challenges that has faced us as clinicians is working out who is likely to develop individual complications and how we can predict the future in systemic sclerosis. So here's another question for, I didn't want to just use Google AI, so I've used ChatGPT for this. So I'm 35 years old. I've been told I've got systemic sclerosis. What is my prognosis? What does the future hold? This is the really important question for anybody living with systemic sclerosis. So this is the AI response. I'm really sorry you're dealing with this. Being told you've got systemic sclerosis can feel overwhelming. One of the nice things about these large language models is that compassion that you get. It does feel like you're having a conversation with someone, whereas Google was slightly more impersonal. In fact, there's probably more compassion here than some of you may have received from your own rheumatologists. Hopefully not me, but and it goes through. It really walks you through in simple English-worded summary what systemic sclerosis is, what are the different types. I think there is a huge amount of information that people can gain from this. Number 3, so supporting clinicians with diagnosis and prognosis. So one of the things that you may have heard about at the course and that many of you may have had is nail fold capillaroscopy, where we use a microscope to look at the smallest blood vessels in the body in the ends of your fingers, just near the cuticle. And we know that patients with systemic sclerosis can evolve from having normal capillaries to these early changes where the immune system is attacking the lining of the blood vessels, affecting the integrity of the blood vessel wall and making them expand into these giant capillaries, and these late changes where you get significant loss of capillaries. And not only is this useful diagnostically, but also prognostically. And we've been using machine learning and AI to help you take these images and actually score them for clinicians and help clinicians interpret the data. So AI isn't just helping patients, but it's helping us as clinicians. This is something that if you do it manually, it's very time-consuming, laborious. AI can do this very, very quickly, can deal with multiple images at once. And then finally, making sense of complex medical interactions. So this is a completely made-up clinical essay, but this is the type of stuff I'll write back to family care physicians to give those physicians an update of how I feel the patient's doing. Now, I know as a doctor, as a rheumatologist, that the family care doctor I'm writing to is not going to read any of this information. This information really is only useful for me at the next visit so I can remind myself what was wrong with that patient. And there is loads of gobbledygook in here and numbers and acronyms and abbreviations that makes very little sense to somebody who hasn't been to medical school. I'm conscious that this is not a good way of communicating with patients, but I would encourage you to use AI. If you're receiving copies of letters like this, you can use AI to make sense of this. So I've asked ChatGPT, can you explain to me what this letter means in a simple lay summary? And actually, I was very impressed with how AI can use very complex information to actually break down that letter and make sense of some of those numbers and abbreviations and acronyms and give patients an idea of what's going on. Now, doing that may throw up more questions for you, but at least then you can go along to your next patient visit and say, I've got some questions about your last letter. What does this mean? Do I need to be concerned about this? Are you going to do this? And again, AI can support this. So hopefully in the last few minutes, I've given you some indication of the strengths and limitations of how we can use AI effectively in the early phases or phase of a diagnosis of systemic sclerosis. I think it is definitely a step up from what we were achieving with Google. There's lots, it's helping not just patients, but also clinicians in this early stage of the disease. I think there are limitations to AI currently. I think it still throws up more questions than answers, but in a way that you can bring those to your physician for more advice and guidance. And so I absolutely think AI is going to play an increasingly important role in the way we're managing our symptoms. And I say we're navigating this process with you, and hopefully this will be a partnership to take us where we need to be. With that, I'm very grateful again for the invitation to talk and happy to take some questions.
Thank you very much, John. This was very inspiring, and I think that we will save the question for last. I can see that they're starting to roll in here, so it's going to be a good panel discussion at the end. And So I would like to invite Janet Pope to the stand. She is a rheumatologist and professor of medicine at Western University London, Ontario in Canada. She has been involved in scleroderma research all her career and is a founding member of the Canadian Scleroderma Research Group. She has received numerous teaching and research awards and has published more than 650 peer-reviewed articles, many in scleroderma, which we are more than thankful for.
Great, thank you very much, and I feel very honored to be here. It's always more difficult to talk, I think, to our patients in an educational format than our peers, where our peers have come in with, a knowledge after medical school in general. The other thing is Annelise said two things that were interesting. She asked, how many have used AI in the last week? And by the way, all of you have, if you've done online shopping. If you were online and a pop-up ad came, it's an algorithm that is targeted to you. And getting your boarding pass, or if something was changed and transitioned to this, to flying here, or when you return back to your home country, AI will be on top of it. So we use AI all the time, integrated into all sorts of things, sometimes knowingly and sometimes not. The other thing she said was, don't give your personal information. So you'll see I decided to give a perspective from ChatGPT because it's open and it's free. So I didn't use a paid-for version, and I didn't use OpenAI, which is a medical version. So I used ChatGPT, and I decided to go from the perspective of a patient, a healthcare provider that doesn't know about scleroderma, and then a researcher with a very specific question. And other than not giving your personal data, it's really important that a prompt is long. So you saw Dr. Pauling's prompt, that the prompt should be long enough that you get a good answer, or you can continue on in the dialogue. So these are my disclosures. So these are the concrete information that I will try to provide that it can be helpful. So instead of a prompt, tell me why I have pain with my scleroderma, you're going to get like 10 pages of stuff, difficult to weed through it. So I said something different, which is still generic, but relative to a patient per se. I am a person living with scleroderma. Tell me about pain. How common is it? What is it from? And what can I do about it? I have gut involvement and a finger ulcer, and my skin is itchy with some cracks and firmness. I have heartburn, which is after anything I eat. So I have asked a mouthful there, so to speak. So you get an answer, and there was compassion in this as well. So if you were living with scleroderma, pain would unfortunately be very common. So there's the true and compassionate. And it depends on what organs are involved. What you're describing is your gut involvement, a finger ulcer, tight, itchy skin with cracks, and heartburn after eating, all very typical of systemic sclerosis. These are disease-driven. So then it goes on to say, because you said, how common is it? So by the way, when I first trained, we never talked about pain in scleroderma, which is bizarre because almost everyone I see with systemic sclerosis has pain. It might be intermittent, but it could be chronic pain all the time. And pain can be moderate or severe, and it could be from these various conditions. So it gives you a really nice breakdown in lay language of finger ulcers and why they would hurt and the pain type. And then goals later on in the AI on the same prompt, goals, improve blood flow, promote healing, control pain, and goes on for treatment. Then again for GI, I put the two together because it was a long answer that I got just with the one prompt. So why heartburn is common, pretty universal in systemic sclerosis, to have dysmotility of your gut, your GI tract. Helpful strategies. If still severe, here's things that can be done. So you could actually bring this in, snapshot it, and if you were the patient doing this, and bring it into your healthcare provider. Then the skin tightness and why there would be itchiness, what to do about the dryness and cracking, what to do daily, which made actually really good common sense, and probably even, again, more detailed than what I might tell you about the skin, because my role when I'm trying to see a patient and say follow up is to inform them, make sure that they're getting their prescriptions, that their labs are done and things. So we have two different, not opposing, but competing interests in that time when we're talking to patients. So I thought this was all pretty good. Then other common causes of pain, joint pain, having tendon friction rubs, which is uncommon, muscle pain and burning pain, electric feelings, so neuropathic. And some strategies, treating the cause. Here's what we can do about it. Physical therapy for the tightness and to improve range of motion, hand protection, gentle stretching, etc. So pretty darn good, really. And then it goes on to say there's an emotional side of pain. There sure is. You can be blue or depressed, poor sleep, poor appetite, or even eating as a comfort way to distract yourself, so eating more, eating less. It can affect your social life. You don't want to go out with this heartburn and problem swallowing, and with digital ulcers, you don't want to hold that cold glass of water at the restaurant. And addressing pain improves your quality of life. It's saying it's not about you. This is the biology or the abnormal, the perturbation, the pathophysiology of your disease. When should you call your doctor urgently? This is all from the same prompt. Like, it's actually unbelievable, and this was really quite good. So now it gives a summary. Here's the big picture, and these are the things that you might want to know about. The other caveat that I can tell you is I almost always say, and provide me with references, because the references, you can click on them. You don't have to read a whole article, and it would be written usually not for lay health literacy. It would be written often in a medical text or something like that. But you can read the first lines of the abstract. This is about, problem swallowing with heartburn in patients with systemic sclerosis, and you can read the conclusion. We found that this kind of treatment was helpful. You don't have to read the whole thing. It just gives you an idea of is ChatGPT making it up, or are we on the right path? Now, your healthcare professionals, so primary care, the nurse practitioner, the family physician, even other specialists, they don't know anything about scleroderma. They might have received 4 lines of text in medical school, like for real, because it's rare, and they don't even know about some of the common things like mechanical back pain because they had to learn so many things. So again, this is a healthcare provider. The patient comes in with systemic sclerosis. So they chat GPT. You can leave the room and do it, or you can say, I'll get back to you, but I'm a healthcare provider and I don't know much about scleroderma. I have a patient with pain and she has new scleroderma. She has acid reflux, recurrent digital ulcers, and her skin's itchy, cracking, and tight. What should I do to help her? And can you provide me with references so I can learn more about this patient? So again, I almost mimicked exactly what the patient told me. So principles in pain, and now we're getting a mechanism as well. And you will see that references will come up that you can click, that I didn't put them all in, but they come up on clickables. Digital ulcers, and then here's some of the treatments and what studies have shown, very brief, local wound care as well. Then it goes on to say, okay, what about the acid reflux? What do we do? What are add-on strategies? And what do I do if it all doesn't work? Then they need a scope. They might need a referral. They might need to see how bad the motility is in their swallowing tube, in their esophagus. Then the itchy skin, again, it's giving what it might be from, local treatments, some other medications that are approved or proven now. I've given that the patient has early systemic sclerosis. I didn't say limited or diffuse because if primary care doesn't even really know what that means per se. So you're getting some things that might not be appropriate for certain patients, but you're getting a list, but you're getting the references to click. And then it goes on, it tells you more. You should screen your patient for these things, for pulmonary hypertension, for interstitial lung disease, for renal crisis, etc. So it's telling you even what to do when you didn't even ask that, and it's actually very accurate. And here's a game plan of treating the patient. I thought it was ginormously good. Now I'm going to move on. So they're very similar. So as a researcher, I decided to ask ChatGPT something different. I'm a scleroderma expert, I hope, and researcher, and I want to consider a topical treatment in active digital ulcers in scleroderma patients. I assume that the treatment should improve the pain and ulcers by 25 to 30%, so a decent enough effect size over the placebo, assuming a baseline pain, because I know that from the data we've collected, of 6.5 out of 10 on a 0 to 10 visual analog scale. What sample size should I consider and provide references? So when I'm starting to write a grant, I usually know the references, but if my trainee is learning about scleroderma and is going to be involved in the project, they can take the first trial of something like this, the first try. So define the effect size, so it tells me that, and it says it would be effect size of about 2 points out of 10 on a visual analog scale, maybe even a bit less than that. Here's what you would do to know how many patients you need. Here's how you actually, it's calculated, so I can actually look. I do have a epidemiology, a logical training in biostats. So this is how it comes from. There's references to click as well, and this could be a sensitivity analysis around it. So bingo, this used to take me on a calculator a half hour to an hour or more sometimes, or we'd have to go look at textbooks to look at, here's the prevalence in the one population and another, the between groups difference, the standardized deviation, etc. So it was actually pretty darn good. And then notes on design, and then it often says, if you have a lot of dropouts, here's what you do. These are usually short trials, so dropout rate is low. Here's how you can do an analysis, adjusting for things, even though I didn't ask it, and here's the key references. So this is something that really, really can help me in my research side. If I'm writing a chapter, we were talking earlier, I often say, I need a table, and here's what the rows are, the trials I'm looking at, here's the columns. The year of publication, the sample size, the dropout, the effect size or the change between active and placebo, and then the caveats in discussion of strengths and limitations. Well, that table can be giant, and then I can use it, check the references, modify it, and get rid of, I did it recently, and I got rid of a whole line. It was like a made-up reference, frankly. And I fact-checked everything, but it was something that I didn't put it in a chapter. I used it as a presentation for the trainees to understand, the value of certain trials that were recent in scleroderma. So, it also gives me, as a researcher, here's a summary and stuff like that, so that I can pop right into a calculator and see if what they're telling you is accurate, or you can do it on an online calculator. So really, I think giving a prompt that is not totally specific to you, like you don't say I live in this county and here's my date of birth and stuff, but I'm an X-year-old person, I've had systemic sclerosis for this long, and here are my symptoms, and what should I do about it? And provide me references. Even if you can't understand the reference, you can click on them and get almost like a good take on reading the title and the conclusion even of the abstract. The healthcare providers, they're using Google or AI every day because people come in with common stuff a lot that they know the answers to, and uncommon stuff all the time, or undefined symptoms, like you heard about puffy fingers and Raynaud's. And really for somebody with a different expertise, such as a researcher, we would ask different questions. I want them referenced, and I will always fact check. I don't just put stuff from AI directly into a grant I'm writing, as a for instance. So I hope that this helps you on your journey of what to ask, how much credibility is there, and you could see both our searches were highly credible. So with that, I thank you.
Yes, thank you very much for that, Janet. You gave a very good perspective on who you are and how the questions should be like. So it's all about saying, okay, which role should you be in order to find the information. So now it's my great pleasure to introduce to you Edith Brown. She has been diagnosed 26 years ago and refers to the scleroderma clinic at Salford Royal Hospital near Manchester. For many years, her consultant was Professor Herrick and more recently, Dr. Mike Hughes. She is traveling a lot, I can assure you. She attends the annual EULAC conference every year. She attends to webinars, online conferences from scleroderma patients organizations, not only in Europe, but also in Canada, Australia, and the US. And since 2019, she has worked with the UMRAC scleroderma group as a patient research partner and attended their conferences in Colorado Springs in 2023 and in Barcelona in 25. And the focus is to improve the outcomes in future clinical trials in Roennow and digital ulcers.
Thank you very much. But I've never been to Athens before. That's good. So my scleroderma story, as Annelise mentioned, began 26 years ago. up till then, I'd always been very healthy and I'd had very little contact with the health service. But I suddenly started developing Roennows in my hands, and my GP sent me to the local hospital to see a rheumatologist. That puzzled me. And it was during that first appointment with the rheumatologist that I first heard the words systemic sclerosis or scleroderma. I had never heard those terms before. I'd never heard it before. I also heard 3 other words that he insisted on me understanding. He said that scleroderma is a very rare disease. That didn't sound good. It's a progressive disease, so other organs could be involved. And unfortunately, at the moment, there is no cure. I felt pretty despondent. All I wanted to know was, what is the treatment? And he said, but you won't get treatment here at this general hospital. You need to move, you need to be referred to a specialist scleroderma centre, and you have 2 choices, and that would be Royal Free Hospital in London or Salford Royal Hospital near Manchester. That, I found, was amazing. It was the year 2000, and the UK had a population of 59 million people and an excellent health service. But my lovely rheumatologist could only recommend 2 scleroderma centres for me to choose from. I slowly began to realise what it meant to have a very rare disease. A rare disease was certainly very lonely. A rare disease diagnosis is certainly very frightening. And a person with a rare disease has very practical problems. I know that if I'd been diagnosed with asthma or diabetes, then any other common disease, my family doctor would have been an expert. I would have been able to access an excellent clinic in any of the general hospitals around me. But a rare disease is certainly very different. A person who is diagnosed with scleroderma who happened to live in the north of Scotland or a tiny village in Wales or in Northern Ireland would have an enormous challenge just to access an appointment with a scleroderma specialist. I was comparatively fortunate. I lived in England, so I was given the choice between London and Greater Manchester, and I obviously chose Manchester. It was only 28 miles away, so the journey wasn't too difficult. When I arrived at the scleroderma clinic, I was very scared. I was very worried about what the future would hold. And the first person I met, of course, was the wonderful Professor Ariane Herrick. I still didn't know what to expect in the future. What I found after my first few appointments at Salford was this was a clinic that provided an excellent level of care. It was also a clinic that was very much focused on research. That was encouraging. I also found that this was a clinic that very much believed in involving patients in the research. I was a geography teacher. I thought I can't be any use to anyone as far as scleroderma is concerned. Patients at the scleroderma clinic at Salford certainly learnt very fast. There was an emphasis on patients understanding their condition. And we certainly evolved a very complicated vocabulary. I learnt words like calcinosis, telangiectasia, vasodilation, capillaroscopy, microvascular abnormalities. I'd never heard any of those words before. These were certainly words you never heard in the Bible. Over many years, the focus on the Manchester team focused very much on capillaroscopy, and I became involved. Well, my capillaries became involved in that research. It was involved, obviously, examining the tiny capillaries at the end of a patient's fingers. If there was abnormalities, then that was a cause for concern. That was a red flag. If the patient had perfectly normal capillaries, then the patient may have Roennows, but was unlikely to be developing scleroderma, and therefore could be reassured on that. My capillaries were very abnormal, so they were considered to be of interest. Because of their work, and it was a lot of work, arduous work, many, many years, trial and error, capillaroscopy is now internationally recognised as a crucial part of the diagnosis of scleroderma, and yet it is still rarely available in a general rheumatology clinic. That is the problem, particularly within the context of a rare disease. The reason why is because it requires specialist equipment, and it also requires a skilled person to capture the images which are clear enough on which to base a diagnosis. Could AI be the answer? These people obviously thought so and have worked on that for many years. The answer is yes, AI is the future as far as capillaroscopy is concerned. The physicians at Manchester, the Scleroderma Clinic, worked with the Salford Royal Hospital, worked with the scientists at the University of Manchester, and they developed an AI computer program which could be accessed by any rheumatologist anywhere in the country. A consulting room, perhaps, he was sitting with a patient many miles away. Using a fairly low-cost device could take images of a patient's capillaries. The computer program would guide the rheumatologist in how to take the correct images, clear enough to make a diagnosis. The AI program would then capture the images, analyze the images, and report back to the physician, many miles away, that these capillaries are normal and therefore the patient could be reassured, or the capillaries are abnormal, like mine, which indicates that the patient could be developing scleroderma, and that patient could then be fast-tracked onto the appropriate course of action. The speed and the accuracy was absolutely essential. And because of that, and because of the dogged hard work of the scientists involved, I think they have really led to a huge improvement in the diagnosis of systemic sclerosis. So I would like personally to say thank you to the Manchester Scleroderma team. It has been a privilege to work with them over the years and notice their hard work and their determination. As for my part, well, it was only my capillaries could claim any credit. My capillaries have been filmed so often over the years that they're demanding their own publicity agent. So the future looks bright. Thank you very much.
Thank you very much, Edith. Such an inspiring story. So I guess that we can all say that AI is here to stay, and we need to find a way how to use it in the best kind of way. There have been dropping in a few questions, and I think that we should take a few of them just here before the break. And a good question here is, let me just see. So we have learned that AI tools can help track symptoms and or disease progression. Do you think that this is we think that this is the future, but how reliable are these AI-based apps or platforms for medical?
So there are certainly a number of smartphone apps that are helping us understand our health. You know, we have watches, we have smartphone apps where you can feed information into those apps, and it gives you information about your sleep quality, what your heart rate's doing. I think it will be really interesting to see in the future how they may support patients with scleroderma to ask their clinicians the right question. I think at the moment, some of the information that's being fed back to users of those types of devices is of questionable value, and that some of the methods they're using probably wouldn't be considered of medical grade quality. But I think there's lots of opportunity for how they will support us in the future.
And I fully agree. Every year at our European meeting, EULAR, or the American College of Rheumatology, or our national meetings in rheumatology, we'll hear about the newest app that tracks patients. As for instance, if they're not feeling well, if usually they walk to work on Monday to Friday, and all of a sudden that's not happening, they're either on holidays, but then the app knows where they are, by the way. We're tracked all the time. Even when you turn off your tracking on your phone, just telling you. But if you're not on holidays, it would almost like in a way alert that this person must be feeling unwell. If it's rheumatoid arthritis, a flare, if it's scleroderma, maybe they just don't feel good, so they've not been able to walk that much that week. Maybe they're taking the bus or something. So there's all these apps, but as a healthcare provider, the last thing I want is 50,000 data points a week on every patient. Like, it would be impossible. So a person knows when they're feeling unwell, so to send it to someone else, I think is highly unhelpful at this point in time. However, I think over time, probably labs can be tracked by by patients. There's already that's happening, certainly in areas of North America and probably elsewhere. So if you get low blood when your stomach is bleeding from ulcers, your esophagus, or watermelon stomach and things, it can track before you start feeling more tired, as if, for instance, that your hemoglobin's falling, see your doctor, ask these questions, get something done, like little alerts. So I think we are in infancy and that these things can be helped. For a personal tracker, though, I think in some ways it's a better summary than, say, if you're writing in a diary. You don't want to also dwell on, here's why I feel bad all the time. Like, in general, with mindfulness, we're trying to have people dwell on, it looks like these are the better times of the day, so this is when you can conserve your energy and do the stuff you want to do, like visit the neighbor or call your daughter or, watch the grandkids, stuff like that. So I think there's value in some of these apps that, when used, that gives satisfaction and value to the user. But at this point in time, most things like this, as you heard, they're not health grade sort of thing, and they're not ready for prime time.
I'll share one other concern I have is, having looked after many people with systemic sclerosis, I'm always amazed at how well people cope with their disease. And so some of these patient-reported outcomes that some of the smartphones are capturing, I have definitely encountered many times patients who say, I feel I'm all right. And sometimes I'll say, actually, I don't feel you're as well as you are. But I think humans are very good at habituating, adapting, learning to cope with difficult and challenging symptoms on a daily basis. And sometimes that isn't giving us the full picture. So I'm certainly not yet happy to manage patients from afar just by them telling me I think I'm okay, because that's concerned that isn't always the case.
Thank you very much. So let's see. Here's a very good question, which I would like all of us, including myself, to answer, because you have all seen out in the lobby that there is this poster about artificial intelligence in AI, and this is a new research project that is being done to collect face and hand data, able to teach AI to learn and recognize systemic sclerosis. Is this the future? Is that a good tool to help diagnosing scleroderma?
I think so. I think one of the main things about AI, and certainly the apps, is it encourages a patient to have responsibility for their own health, particularly things like sleep and exercise and blood, heart rate, etc. And I think that really does encourage people to be more proactive and to work with the professionals rather than just receive the wisdom from the professionals, to realise that you have got your own part and you have got your own responsibility to play. And the apps, certainly iPhones and things like that, could really encourage people to be more proactive.
And I think answering, when you do go to Google Images, as you heard earlier, you often see the worst case scenario, and it's actually kind of scary. And even as, if I'm not a specialist in an area and we look something up and you go, oh my goodness, that's not what my patient's rash looks like, but I think she has lichen sclerosis, but I'm seeing the worst case scenario. So I think training AI is helpful for the patient to take the responsibility of asking the first questions. Hey, my ring size is, I have to upsize my ring. It doesn't fit now. All my fingers are puffy. My fingers go stark white. Everyone's commenting on it now. And I see little things at my nail bed or cuticle that don't seem to make sense. If that's kind of what you're thinking, and pictures could help, you want pictures in a spectrum, particularly of early changes, so that a diagnosis can be made. potentially made so that it can be investigated. But just realize always when it's early things, there are false positives. And that scares people. It's like anyone in the room that's had a mammogram that shows something and it's very scary until that false positive is confirmed to be truly not the case or needs further investigations, etc. So I think that this will be the future. AI is reading pap smears. AI is reading kidney biopsies in some centers. AI is absolutely reading radiology tests in centers and flagging abnormals, etc. But there will always be an error margin. So fortunately, the healthcare providers will still have jobs, but they will be more informed when the patient is a partner.
I agree with both my panel members on all their points. I think I would also add that it's essential these tools have full representation, that they're not being informed by a very homogenous patient cohort. And we know already that medical textbooks often are filled with images of white people, and I think sometimes that can lead to inequalities in healthcare access. The second point I would make, which Janet has alluded to, is we see forms of systemic sclerosis where people get no puffy fingers, no skin involvement to their fingers. They get Raynaud symptoms, and they can develop quite significant scarring on their lungs or problems with the blood vessels in their lungs, but really with very little otherwise in terms of visible signs of systemic sclerosis. And I would definitely want to guard against people being reassured they haven't got a condition just because they don't look like they have the condition on the outside, because we know that absolutely isn't the case.
Yeah, and I totally agree with the rest of the panel. I think the project is very interested, and what I see when I put on my critical eyes is that you are developing, there will be a developed closed environment that is going to be trained on real data, which we're providing this project. And that is a very good thing, because it then protects our data. And it's very important that we have protection of the data. And there are so many different kind of large language models, not only ChatGPT, but we also have Perplexity, Claude, and whatever they're called. And a thing that is important for us as patients is that we have to protect our data. And it has to be GDPR or what it's like. I can't get the right words, but it's very important that protection of data is #1 priority, basically. So are there any more questions from the audience? I know that many of you might be eager to get to lunch, but before you just run off to lunch, I want to invite you back here into a very, very exciting roundtable discussion about what's new in systemic sclerosis treatment. And this is something that is always interesting when we come year by year. The speakers will be Sue Farrington, Michael Erskar, Brian Lee, and Shervin Asasi. And lunch is out in the lobby. And yeah, and please get back to here as soon as possible. But don't swallow, don't choke in your lunch. We want you back here. So nice and easy, and enjoy your lunch. Thank you.